Good evening, everyone, and welcome to 365 Live. My name is Bina, and I'll be your host for tonight's session. 365 Live is a platform where we educate the public on cancer and encourage a cancer prevention lifestyle. This is a gentle reminder that all information shared at this event by the speaker and 365 CPS are general information only and subject to changes. Do consult your doctor for personalized and detailed medical advice. Without further ado, I'm pleased to introduce tonight's speaker, Dr. Tan Yu Guang, who is an Associate Consultant of Urology at the Singapore General Hospital. Dr. Tan is also a clinical professor at the Duke NUS Graduate Medical School. He'll be sharing with us more about prostate cancer tonight. Hi, Dr. Tan. Thank you very much for joining us tonight to share your knowledge with everyone. So, what is prostate cancer and what should we know about PSA testing? Let me hand over the time to Dr. Tan to answer these questions. Dr. Tan, please.
Hey, thanks a lot, Bina. Very good evening to everyone who has taken time off to join us in this evening session. I'm Dr. Tan, a practicing urology at the Singapore General Hospital, and my interest is in management of urological cancers. This month is November, and we celebrate Movember, which is a movement to raise awareness on men's health and prostate diseases. So in the next 30 minutes, I'll share with you a very common topic that everyone talks about today regarding prostate cancer, understanding prostate cancer, and the natural history and implication on prostate cancer testing. So these are the outline of my presentation. I'll start off by trying to give an illustration and understanding on prostate cancer, what we should know about prostate cancer testing via the prostate-specific antigen, or PSA for short, what happens after one has a PSA testing, and some of the take-home messages. So the prostate is a gland that sits below the bladder and surrounds the urethra and is part of our urinary tract system. Its main function is to produce fluid and nutrients for sperm. And unfortunately, as you age, two issues may surface. One is a benign enlargement of the prostate, or what we call BPH, and second is prostate cancer. So the first part of it, in terms of benign prostate enlargement, this is a non-cancerous enlargement of the prostate, and it tends to grow from the central part of the prostate where the urine transverses, and it grows externally towards the outside of the prostate. And therefore, it tends to cause a lot of urinary symptoms very early in the disease itself, and one may present with poor flow, hesitancy, urination at night, or incomplete emptying. And this is in stark contrast to prostate cancer. And in fact, early stage prostate cancer is almost often completely asymptomatic. The reason is because, unlike prostate enlargement that starts from the central part of the prostate cancer instead tends to start at the border or the periphery of the prostate gland. And only in later stages, as it grows toward the central part of the prostate where the urinary tube is, it will cause significant flow issues. So prostate cancer, unfortunately, is rising throughout the world. It's now the most common malignancy affecting men. And in fact, 1 in 8 men will be diagnosed with prostate cancer in their lifetime. I would like to share with you the data from the Singapore Cancer Statistic. You can look at the top diagram. This is the Singapore Cancer Statistic data in the incidence of cancers in 2020. And the bottom diagram shows the latest in 2024. And as you can see, in 2020, prostate cancer is actually the second most common cancer after colon cancer. But by this year, it's now the most common cancer affecting males in Singapore. However, fortunately, if you look at the mortality or death from prostate cancer, it's actually only ranked number 6. And it's actually a lot lower than other cancers such as colon cancer, lung or liver cancer. So it's clearly that although it's the number 1 in terms of the incidence of prostate cancer, not everyone will die from or suffer from complications of prostate cancer. So the real question is, does prostate cancer really kill, and who does it actually affect? So it's important to understand the natural history of prostate cancer. Unfortunately, prostate cancer usually takes many years to cause death, and we'll say somewhere between 10 to 15 years. That is to say, for the elderly patients who are usually more than 75 years old, they are more likely to die from other medical conditions. only in the young, healthy, middle-aged men aged between 50 to 70 years old with minimal other health issues, prostate cancer mortality may become more significant in this group of patients. So in fact, we can potentially leave the cancer untreated. This was a study from the Swedish population where they had 223 patients with localized prostate cancer untreated and followed up for a mean duration of 21 years. So you can see, even if you have prostate cancer, you can be followed up for up to 21 years. And in fact, for the younger patients, less than 70 years old, they may be at higher risk of to experience disease progression or prostate cancer-related death. But if you look at elderly patients more than 70 years old or even more than 80 years old, they are more likely to die from other causes. And prostate cancer-related death only attributes to less than 5% of mortality. And in fact, we also again look at the duration of follow-up to the time of event, which is prostate cancer-related death. And most progression or death only occurs after 15 years of follow-up, and this is despite no treatment. Unfortunately, we also have some local data to look at the natural history of prostate cancer in Singapore. In Singapore General Hospital, we actually had 204 patients with prostate cancer untreated, or what we call watchful waiting, with a median follow-up time of 13 years. And only 19 patients, which comprises less than 10% of patients, actually die from prostate cancer. And more than half of the other patients actually die from other natural causes. And in fact, if you look at this graph, if I were to take you through, the red represents the incidence of prostate cancer mortality. And you can see over 15 years, the incidence is only less than 10%. And in fact, most of the other causes of death actually are from other conditions, which is highlighted in the blue. And we then do some analysis to see, out of this 10% that might die from prostate cancer, who are more likely, which kind of risk profile of patients who are more likely to die from prostate cancer. So if you look at the diagram on the left, patients who are very fit with minimum comorbidities, which we call it the CCI, also known as Charlson Comorbidity Index, is just a composite score to see what other health conditions that you have. So if you have less than 3, which means that you are generally a very fit, healthy adult, you might be at slightly higher risk of prostate cancer mortality. However, if you have significant other medical issues, poor comorbidities, as shown on the right with the CCI more than 4, then in fact, you are more likely to die from other natural causes or other non-prostate cancer-related causes. So certainly there are some risk factors for prostate cancer, one of which is age, which primarily afflicts men who are more than 60 years old, as you can see from the graph here. Of course, there are also some familiar family history that might contribute to prostate cancer. Fortunately, this only contributes to less than 10% of newly diagnosed prostate cancer. On the other hand, there are some environmental factors that may contribute to prostate cancer, one of which is obesity, which has been shown to be associated with higher risk of advanced prostate cancer, as well as more aggressive prostate cancer. And of course, the second is smoking. I do have some patients who often ask me, what should they eat in order to bring down their prostate cancer marker or prevent prostate cancer. To this date, there's currently no effective diet or medicine to prevent prostate cancer. But I do tell my patient, healthy lifestyle can never go wrong, and healthy lifestyle in general has been shown to reduce all cancers in general. And next, we move on to screening for prostate cancer. Most commonly, this is done via a blood test called the prostate-specific antigen, or PSA for short. And in fact, most of the healthy SG health screening nowadays will incorporate PSA in their testing. And this is the guidelines taken from both the European and American associations for urology. And you can see across the board, be it Europe or American, most countries will offer screening for healthy adults between 50 to 70 years old. But it's also important to note, above 70 years old, screening for prostate cancer is generally not recommended. And this is in line with our understanding of prostate cancer that takes more than 10 to 15 years to really cause progression or death. And a little bit more about PSA. This is actually produced by both normal and cancerous prostate cells. However, in prostate cancer, the cells tend to be more disorganized. Therefore, more PSA is actually leaked into the bloodstream. PSA itself is organ specific to the prostate, but not disease specific, meaning there are other conditions that can cause elevation of the PSA, and this includes prostate enlargement or BPH that we have previously talked about, prostatitis, which is inflammation or infection of the prostate, and certain lifestyles such as regular cycling or even a recent digital rectal examination. And PSA itself as a screening tool is unfortunately not very sensitive. If you compare this to other screening tests that we have in Singapore, be it mammogram for breast cancer or blood test for colon cancer, the sensitivity of PSA itself is only about 30 to 40%. What it means is that even with a low PSA, it does not exclude you from prostate cancer, but it does exclude you from very aggressive prostate cancer. And what else should be done after you have your prostate PSA testing? And unfortunately, the results turns out to be elevated. So for many years, up to the 1990s and even 2000s, what your urologist may offer is what we call a transrectal ultrasound-guided prostate biopsy. In the nutshell, ultrasound probe is placed into the rectum, and the biopsy needle will be inserted through the ultrasound into through the rectum into the prostate, which is just located anteriorly. Unfortunately, there are certain concerns regarding this approach, one of which is the high infection risk, because the needle itself is transversing through the rectum before it reaches the prostate. And we know that the rectum itself contains a lot of bacteria that increases the infection risk. Second is that we're actually unable to identify where in the prostate the cancer might be. And often what we do is a random 10 to 12 tissue biopsy. And this leads to the overall accuracy of a transrectal ultrasound-guided prostate biopsy of only about 60 to 70%. Therefore, what has really been a game changer in the last 10 years is the role of imaging, in particular MRI prostate. And this is really what we offer to every patient with elevated PSA being referred to the Singapore General Hospital today. The MRI prostate really allows us to see the tumor for the very first time before you have a biopsy. And if I can, draw your attention to the graph, the MRI on the bottom right, if you can see in particular the image on the bottom left, you can see where the yellow arrows are pointing to. Their areas are actually whiter compared to the rest of the prostate gland, and these are the areas that are suspicious for prostate cancer. And with that, this can potentially allow us to have very targeted biopsy on the areas that are suspicious for prostate cancer. So certainly, there are also studies that align regarding changing from upfront biopsy towards an MRI pathway. And this was a landmark study that actually they randomized patients with elevated PSA to either upfront biopsy done through the transrectal route versus MRI, and only if you have suspicious lesion in the MRI, you follow up with a biopsy. And in fact, patients who go through the MRI pathway had 28% of them can avoid unnecessary prostate biopsy if the MRI was negative. And more importantly, if your MRI is suspicious and you go for a prostate biopsy, is able to increase the detection of aggressive prostate cancer. And certainly, this has been how we practice in the Singapore General Hospital today. We have moved on from a transrectal ultrasound prostate biopsy, which has an infection risk of 3 to 5%, to a transperineal prostate biopsy. So basically, instead of having the biopsy needle going through the rectum where a lot of bacteria resides, we go through this area called the perineum. And this perineum is a skin area that is just behind the scrotum and in front of the rectum. And this allows us to directly biopsy the prostate without going through the rectum, and this significantly reduces the infection risk to less than 0.1%. In fact, in the older days where we do a transrectal ultrasound prostate biopsy, we do have to give patients up to 2 weeks of antibiotics. But as we transit towards a transperineal prostate biopsy today, we no longer prescribe any peri-procedure antibiotics for this group of patients, and this is still able to achieve an infection risk of less than 0.1%. And what has been really the game changer today is what we call a robotic biopsy by fusing the MRI and the ultrasound image to allow us to biopsy the MI suspicious area with very high accuracy. And in fact, we are always proud to share that, in SGH, we were the pioneers in developing what we call robotic biopsy. This was a platform developed by us, and we had a patency for it. And this is actually a very common platform that's used across all public institutions and private hospitals across Singapore today, and in many of the international communities and specialist hospitals. And what it does is that on the day of the operation, we will do an ultrasound of the prostate to measure the prostate image. We will then import your previously performed MRI image, and we will do what we call a 3D fusion of the MRI and also the real-time ultrasound image. And this is what we call the composite 3D model. So in that aspect, you are able to see the MRI suspicious areas on the ultrasound itself. And following which, we then can achieve very targeted biopsy aimed at the MRI suspicious areas. And this certainly increased the accuracy of our prostate biopsy. So to summarize some of what we have talked about, prostate cancer, newly diagnosed prostate cancer is certainly very, very varied. It can start off from very early stage, low risk prostate cancer, and to the more aggressive, high volume aggressive prostate cancer. And certainly there's really many options to tackle prostate cancer today. For the early stage, low risk prostate cancer, what we offer patients is active surveillance. And in fact, the overall survival in this group of patients with early stage low risk prostate cancer is up to 99%. And therefore, really, there's even question whether this group of patients are truly called cancerous in nature. So for some of the early prostate cancer which are low volume, what we do in SGH today is what we call focal therapy, where we actually treat the small area of the prostate that harbors the cancer cells and spare the rest of the prostate itself. And this allows us to preserve some of the function of the prostate gland, preserve sexual function, and also reduce incontinence associated with other treatments. However, for a certain group of patients with more aggressive prostate cancer or higher volume prostate cancer, whereby we can treat the small area of the prostate gland itself, we have to offer what we call a radical treatment, where we remove the whole prostate. This can be done via a robotic surgery. In Singapore General Hospital, this is done through, we have 2 robots today. It's usually about 3 to 4 hours operation, and up to 95% of our patients will be discharged within 24 hours. Robotic surgery is often offered to younger patients who can tolerate surgical stress. However, in the elderly patients who have more aggressive prostate cancer and where surgery is prohibitive, they go for radiotherapy. And again, today we also have proton beam therapy in some of the centers. So these are my take-home messages. Firstly, prostate cancer is common, but it's not always deadly. Urinary symptoms, if present, are likely due to concomitant prostate enlargement, as early prostate cancer is often asymptomatic as it starts from the periphery of the prostate gland. PSA itself as a testing is imperfect given the limited sensitivity, but often it's the starting point where further investigation will take place. One of which today is imaging with MRI that can help you decide whether you truly need to undergo further prostate biopsy. And today, with a transperineal approach and an MRI and ultrasound fusion approach, this allows us to have very accurate biopsy techniques and achieving very good safety with minimal infection risk. And lastly, always speak to your urologist to provide you the most accurate information for your condition. And with that, I have come to the end of my presentation, and I'm happy to take some of the questions or queries that you might have.
Thank you, Dr. Tan, for your comprehensive and informative sharing. It was interesting to learn about the tests used for prostate cancer diagnosis, and I hope everyone has also learned more about prostate cancer and its early detection. If anyone has any questions, please feel free to share them in the chat and we will address them accordingly. So currently we have a question from Shan Shan. So the question is, if there's blood in the urine, is it confirm that it's because of cancer?
No, thanks a lot. Thanks, Shan, for raising this question. I think this is a very common condition that we manage in our clinic. If there's blood in the urine, it's called hematuria. And in fact, we get a lot of referral for what we call microscopic hematuria, where you do a health screening, you don't see blood, but the health test comes out to have some blood in the urine. So this is what I call microscopic hematuria. So when there's blood in the urine, it tends to arise from any part of the urinary tract. So you can look at the kidney, the ureters, which is the conduit that brings kidney down to the bladder. Then for men, you have the prostate. Therefore, if there's any abnormality in any of the urinary tract system, then you might have a chance of having blood in the urine. And often, this is not limited to cancer. More often, it's the benign condition that actually causes blood in the urine. So for females, most common is urinary tract infection. In fact, studies would show that more than 80% of females will have 1 to 2 episodes of urinary tract infection in their lifetime. So, a part of just having blood in the urine will ask some other symptoms such as, do you have pain when you pass urine? Do you have burning sensation? Do you have a lot of urinary frequency whereby you need to go toilet every 30 minutes or so to pass urine? And these are the association with, when it's associated with blood, this really gives you the diagnosis that the patients are likely to have urinary tract infection. The second most common cause of blood in the urine is in fact stone diseases, which again is very common in our part of the country. One of which is because we are often dehydrated, we don't drink enough water, and certain diet. I think a lot of us likes to take nuts because it helps to boost our brain, all this. But nuts are actually associated with this thing called oxalate, and it's oxalate rather than calcium that forms stones. And oxalate is present in a lot of nuts and even chocolate, which many of us like to have that. So when you see a urologist, of course, everyone is worried about cancer of any of the part of the urinary tract. So we do some of the comprehensive assessment. We do some of the urine test to exclude infection. We actually do a CT scan or ultrasound to look at the urinary tract for any stones or any abnormal growth. And we will discuss that with the patient. So I really think that to answer the question shortly, cancer itself is actually not the most common diagnosis for someone with blood in the urine, and it's most often due to some of the non-cancerous condition. But of course, we will do the necessary workup to make sure that we have adequately addressed your concern.
Thanks, Dr. Tan. We have also another interesting question from Sarah. So if an elderly man has enlarged prostate, can it lead to bladder cancer, or is it like two separate conditions?
Good question. So in fact, prostate enlargement and bladder cancer are two separate conditions. Having an enlarged prostate does not lead to bladder cancer. The most common cause of bladder cancer is actually smoking. Smoking actually increases the risk of bladder cancer up to 11 times. And bladder cancer is actually the number 7 most common cancer in Singapore in general. So they are not related to each other. But certainly, in elderly patients, like I said, they are likely to have a prostate enlargement. They can also have bladder cancer because it's also age-related.
Thank you, Dr. Tan. So I guess it brings us to our next question, since it's age-related, right? So when should men in Singapore start screening for prostate cancer? I think you mentioned like in the US, the guidelines may be like 50 to 70. So is it the same also in Singapore?
Yes. So in fact, the MOH guideline, prostate cancer screening sometimes can be controversial because, you don't want to have open the can of worms where you start screening patients who are even like 75 to 80 years old in general. So, in the MOH guideline, even in our Singapore Urological Association, we tend to say that, this is a shared decision where we discuss with the patients, we look at them in terms of their life expectancy, their other health conditions. But, to give a more objective answer or to the question, I would say that for someone between 50 to 70 years old, we tend to offer prostate cancer testing because if we were able to screen them early and pick up early stage prostate cancer, we can discuss with them whether, do they truly need treatment, what kind of treatment do they need. So I would really keep it to somewhere between 50 to 70 years old. Sometimes 70 to 75, if they are really very fit and well, they understand the implication of prostate cancer testing, then I will offer that to this group of patients.
Thank you, Dr. Tan. So we have a question from Claire. So how can younger men prevent the development of prostate cancer? So like I guess when you mean like somebody is fit, so what constitute the definition of being fit?
So I think generally we haven't had a real diet or that helps to reduce prostate cancer. In the past we talked about having more tomatoes that actually reduce prostate cancer, but it hasn't really shown to be that effective. I would say to this day we don't have what we can do is really having a healthy lifestyle and exercising, and that has consistently been shown to reduce all kinds of cancer. For prostate cancer in particular, I would say, avoid obesity and smoking, which are probably the only two risk factors for prostate cancer. In that case, if you are concerned, if you are in the appropriate age group, you can consider prostate cancer screening, and that really allows us to identify very early prostate cancer and give that sense of reassurance in how we manage prostate cancer.
Thank you. So we have a question from Eileen. So if a father passed on due to prostate cancer, how high is his children's risk for prostate cancer?
So thanks, Eileen. In fact, having if your father have prostate cancer, what you are concerned about is whether it's hereditary in nature. In fact, like I said, hereditary prostate cancer is actually really rare. It's less than 5%. And if you have a family member of having prostate cancer, it does not really increase your risk of prostate cancer. What's important to know is the age where your family member had prostate cancer. Because like I said, 1 in 8 men will have prostate cancer. So it doesn't mean that their offspring will always have a higher risk of prostate cancer. Some of the hereditary prostate cancer or genetical linked prostate cancer is where you have a family member who has very early onset of prostate cancer, less than 50 years old or even less than 55 years old. Then we are concerned that there might be some genetic mutation. The other group that we are concerned, if you have mothers or sisters having strong history of breast or ovarian cancer, so they are actually, interestingly, the gene that causes breast and ovary cancer, we call it the BRCA gene, is actually linked in prostate cancer. So in my clinic, I'll ask them if they tell me that they have a family member who have prostate cancer. I'll ask specific question like, how old do they have prostate cancer? Was it an early or late stage of prostate cancer? Do they have a mother or sisters that has other breast or ovarian cancer? So to really conclude that question, I think having a father that has prostate cancer, the risk of hereditary prostate cancer itself is not high. It's really not high.
Thank you. So if their mother or sister has that BRCA gene, then would their prostate cancer also be more aggressive? Has studies shown that, or it's just a correlation there?
Yes. So yeah, right, Bina. So if you do harbor the gene mutation, which is BRCA gene, and in fact, if you have a strong maternal history or sisters having breast or ovarian cancer, they actually, the National Cancer Guideline will actually advise screening for the gene mutation, or what we call the BRCA gene. So if the male offsprings also have the BRCA gene mutation, you are more likely to have prostate cancer earlier, less than 55 years old, and you are more likely to have aggressive prostate cancer. So in fact, some of the guidelines would say that if you have a BRCA gene mutation, you start prostate cancer screening or testing from 40 years old onwards.
Thanks, Dr. Tan. So I guess it's a follow-up question from Shan earlier, who asked about blood in the urine. So he just wanted to clarify whether this blood in the urine can also be caused by kidney stones. I guess that's what you shared, right?
Yes.
Earlier on.
Yes. So certainly, yeah. Kidney stone can cause blood in the urine. Most of the time, it actually causes a lot of pain. What I always tell my patients is that, as the stone moves down the urinary tract, it can cause a lot of friction, and with that, it can cause a lot of blood and a lot of pain also.
Thank you. So there's a question from Ming Hui. So it's sort of related to the ovarian cancer topic earlier on. So this person asked, if my mother has uterus cancer at 79 years old, will I be prone to prostate cancer? He will soon be 55.
Okay, thanks a lot, Ming Hui. I think to give you the reassurance, certainly I don't think you are at higher risk of prostate cancer. your mother had unfortunately had uterus cancer at 79 years old, and she has lived to a ripe age, and therefore as you grow older, your cancer risk in general increases because there will be a lot of mutations in our cells as you grow older. But I certainly believe and give you the reassurance that you are not at higher risk of prostate cancer. But certainly, you're coming to 55 years old, you have minimum, you lead a healthy lifestyle, you have minimum other health conditions. I will actually consider you having a PSA testing. And generally, I would say that if you have a normal PSA testing, you don't actually need to do it every year. Most studies, actually most guidelines will recommend PSA testing minimally every 2 to 3 years, or even longer at 5 years. So really, you do not need to do any PSA testing on a yearly basis.
Thanks, Dr. Tan. So apart from like screening, after somebody gets diagnosed, and if it turns out that someone has to undergo surgery to remove the prostate, so what is the procedure like, and what are like any side effects that the patient would experience?
Yep. So, for more aggressive prostate cancer, the best treatment is complete removal of the prostate, and you can either remove it via surgery, or you do radiation where you completely burn the whole prostate. So each of them are equally effective. Okay, when we talk about effective in treating prostate cancer, early stage prostate cancer, we are looking at about 80 to 90% cure rate, and this is actually very high compared to other cancer. So in surgery, what we do is what we call robotic surgery, where you actually have small holes we make small incisions in the tummy, and we will remove the prostate, and we will join the bladder to the distal part of the urine tube. This is usually done, you come in on the same day, you do the operation, and you get admitted. Most of the time, the operation is about 3 to 4 hours, and you get, like I said, more than 90 to 95% of my patients will be discharged within 24 hours. You will need to have a urine tube inside you to drain the urine for about 5 to 7 days. This allows the joining part to heal also. So usually, you come back about 5 to 7 days later, and the nurse will help to remove the catheter. The two unfortunate side effects of surgery is, one is sexual dysfunction or erectile dysfunction, because some of the nerve that supplies the penis for erection actually runs very close to the prostate gland. And sometimes in more advanced disease, we do not try to spare too much of the nerves, because that will make us very close to the prostate gland itself, and this increases what we call the chance of having residual cancer left behind. So in fact, I would say, to be honest, about 50 to 70% of patients will feel some deterioration in their sexual function that may need some medication to support. The other side effect that everyone talks about is urinary incontinence or urine leak after surgery. But the key note about this is what we call transient. So this is temporary and not permanent. This is because of how the surgery is done. But importantly, the most important pelvic floor muscle is actually preserved. So I would say, for the first, in our cohort, most patients the first 3 to 6 months will have some urinary incontinence. How much is it? They usually will leak a little bit, a few drops when they cough. And I would say, when females use pad for their menses, similarly, men will use those pads, about 2 to 3 pads for the first 3 to 6 months. And most studies, or in our experience, I would say only about 5% of patients will need to use more than one pad after 6 months. So in fact, I would say that some of these urinary incontinence are early, but usually they are not permanent. The other hand, when it comes to radiation, although it burns the whole prostate, the challenge is that some of the radiation actually goes to the bladder and also the rectum. So they do have a small risk of bleeding when they pass urine or pass motion in the future. So that's always the consideration, especially when you grow older, you're on blood thinning medicine, that will significantly increase your risk. So what we do in the last 5 years or so is this thing called focal therapy, which we offer to our patients. If your prostate is really very small and very treatable in around the area, so what we do is that we actually burn only that area where the cancer is, and we spare the rest of the prostate gland, and that really eliminates the incontinence risk, the bleeding risk, as well as the sexual dysfunction.
Thanks, Dr. Tan. So, if I understand correctly, so that urinary incontinence is sort of like a temporary thing, like after
Yes,
like maybe 6 months onwards, that like the
yes,
patient wouldn't experience that.
yes. I would say 95% of patients really will not have significant urinary incontinence after 6 months.
Okay, but the sexual dysfunction will
Might be a
continue.
bit more permanent. Yeah.
Okay, might be okay. Interesting. Thank you. Let me see. Um, we have a question from Sarah. So, is it common for an elderly with enlarged prostate to pass out cloudy or bloody urine?
Yes, thanks, Sarah. So certainly, those symptoms are very common. But what the problem with enlarged prostate is that the prostate is actually a very vascular structure. It means there's a lot of blood vessels that goes to the prostate. That's why it can keep growing to such a big size. And therefore, it is prone to, some of the small vessels may rupture and it can cause bleeding. What is important also, they have this thing called incomplete emptying. Means, even after they urinate, they still have urine that's left behind, or what we call residual urine. And this residual urine becomes a reservoir of nidus or infection. And when you have infection, the most common symptom is that you start to pass out sediments or cloudy urine, you have burning sensation. So these are really the symptoms. And it really shows that your prostate enlargement is actually quite significant, that you are starting to have complication arising from that condition.
So, I mean, on this note, since like you also mentioned that a lot of times men just have like enlarged prostate instead of prostate cancer, right? So, what are the like treatment options for enlargement of the prostate?
Yes. So that the good thing is that we have tons and tons of treatments for prostate enlargement today, and this will be like a 30 minutes to 45-minute session. But I'm happy to share some of that. In the past, you only have two treatments. Either you go on medication for life, or you do a surgery where you actually scrape a prostate. So basically, what I tell my patient is that a camera goes into your prostate, and you imagine your prostate is a coconut. So basically, I'm scraping all the flesh, which is the white, and I'm leaving just the husk, the brown part of the coconut. And that's what scraping does. But some scraping itself has issues of it can affect your some of the sexual function. It can have bleeding risk. So some patients are quite adverse to it, especially the younger patient where sexual function is important. So in the last 5 years, again, there's a lot of what we call minimally invasive surgical treatments. These are all like 5-minute procedures that actually can give very reasonably good outcome for prostate enlargement. So increasingly, I do tell my patients, especially the young patients who have a very sizable prostate, I say, if I were to start you on medication, I kind of treat your condition like a chronic condition like hypertension, diabetes. Now we have the technology to do a 5-minute procedure to really solve your 20, 30 years problem. So it's actually not a bad consideration, and these treatments actually, they are a lot more cost effective than traditional treatments, surgical treatments. So these are some of the consideration or some of the things I lay out to my patient.
So, if like it enlarge and then you do the procedure and then it becomes smaller, would there be a chance that it enlarges again, like
Yes,
in the
yes,
future?
yes. But that generally, most studies will say that it takes about 10 to 15 years.
Mm,
So sometimes I jokingly say that it's kind of like COE, right? You do one time, you get a 10 years. But I think 10 years for a 5 minutes procedure where you are off medications and the side effects of medication, I think in certain group of patients, I do think that this is a very cost effective and a worthwhile consideration.
agree. Like just taking the medication every day consistently for 15 years can be quite a bit of effort on the patient's part. So we have a question from Shanshan. So she's concerned. Her father is 64 years old this year, so she's wondering if like she should suggest for her father to go for a PSA screening test. And of course, like you mentioned, that PSA is not 100% accurate. So what is the false negative rate for this test?
Thanks a lot, Shanshan. I think you really brought an important point, because I mentioned that PSA is not accurate, then why are we still doing PSA? So unfortunately, PSA is probably the only blood test that we have as a screening tool for prostate cancer. we always use a PSA, a score of 4 as a cutoff. And this is actually a very arbitrary cutoff. And I agree, if you less than 4, the chance of prostate cancer is actually can be present about 20% of patients. So less than 4, you have a 20% chance of having prostate cancer. But these are all very early, non-aggressive, low-risk prostate cancer, which I told you about active surveillance in my last few slides. So less than 4, studies will say only about 4 to 5% of patients may harbor a little bit more aggressive prostate cancer that may require intervention. That's why, as an international community, we decide with a cutoff of 4. And generally, you don't have to worry too much, because I would say that if you have a PSA of anything between 4 to 10, even if you have prostate cancer or aggressive prostate cancer, these are all early stage localized prostate cancer. It's highly unlikely that you, with a PSA of less than 10, you have prostate cancer that spread to the lymph nodes or even the bone. And in fact, if I have someone who has prostate cancer diagnosed between 4 to 10, sometimes in some of the guidelines, they will not recommend you to do like a full body CT scan to see any spread to other parts, because it's almost impossible to have that kind of spread. So I think that, PSA certainly is not 100% accurate, but again, it's really the starting point where we actually talk to the patient, whether, as physicians, are we concerned, or is there any other things that we need to be done or investigated?
Thank you. So I think earlier in your slides, you mentioned that cycling can also increase your PSA level. So is it like harder to detect prostate cancer in people who cycle frequently?
Oh, okay. I think what we do is that, I actually ask them, some of them will volunteer. I say, what you like to do in your spare time. When they say cycling, I will tell them that it does increase the risk of increase your PSA, but it does not increase your risk of prostate cancer. What I usually tell them is that, why not, you stop cycling for a month, and we repeat our PSA for you. And if it comes down very nicely to, like 1 or 2, then really I'm not very overly concerned. But if your PSA continues to be a little bit more elevated, then the next thing I will do is actually an MRI. And if the MRI is actually normal, then you really don't need to go through the hassle of having a prostate biopsy.
Thank you. So I guess we can sort of wrap up this Q&A session. So since we have answered most of the questions from our audience tonight. So thank you, Dr. Tan, for your comprehensive and informative sharing. It was very interesting to have this discussion with you. And thank you everyone for your participation in the Q&A tonight. So it's now time for Dr. Tan to take his leave. Once again, thank you very much for your time tonight.
Okay, thanks very much, and thanks to all the audience for supporting 365 Cancer Prevention Society. And thanks very much to the host and the team for putting up this show together. Thanks very much, and I hope to see everyone again.
Thank you. Good night. Do like and share our social media pages for the latest updates on our events, such as this 365 live event. Once again, thank you very much for joining us tonight. I hope to see you all in the next session. Take care, stay safe, and good night.